So the background of our study was the fact that a lot of breast cancer present oncogenic mutation. And we know that targeting oncogenic mutation with drugs could sometimes lead to objective response in this patient. So the question is, should we detect all these mutations in each patient thanks to multi-gene sequencing? So to address these questions, we perform a randomized trial comparing targeted therapies matched to the genomic alteration detected by multi-gene sequencing to a maintenance chemotherapy in patients with metastatic breast cancer. So we perform a phase 2 randomized trial. The study design is the following. Patients who presented a metastatic breast cancer who did not receive more than one line prior chemotherapy and who did not present HER2 overexpression entered in the study. The patient received a genomic profiling either on the tumor sample or on the blood. And if the patient presented a targetable genomic alteration and presented a disease control after 6 to 8 cycles of chemotherapy, then it was offered a randomization between 9 targeted therapies matched to genomic alteration versus the continuation of chemotherapy. So the study tested 2 primary objectives in a hierarchical testing. The first hypothesis was that in patients presenting an actionable genomic alteration ranked level 1 or 2, the targeted therapy could improve outcome. So that was 115 patients who presented a genomic alteration who was previously found to be associated with objective response to targeted therapy. In this group of patients, targeted therapy improved progression-free survival from 2 months to 9 months with a hazard ratio of 0.41. Then the second primary objective was to test whether targeted therapies matched to genomic alteration improved outcome in the intent to treat population who presented an actionable alteration. And in this intent to treat population, there was only 2 months improvement on PFS with a p-value of 0.10, meaning that the study met one of its primary objectives, that is, targeted therapies matched to genomic alteration improve outcome if the alteration are ranked level 1, 2 according to the ESMO scale. So these results have a direct impact on the management of patients with cancer. The first direct impact is that with this result, it's becoming mandatory tomorrow morning to add a ranking of genomic alteration in the genomic report. The second implication of this trial is that there is a benefit for patients of receiving a multi-gene sequencing, meaning that it's important that patients get access to this technology. And of course, as previously mentioned, that the results are provided to the oncologist on an interpretable way with a genomic report that include the level of evidence for each alteration.